Thank you very much, Virginia, and good morning, everybody. I'm delighted to present to you this morning the translation of the findings of the We Can Quit 2 pilot trial of a smoking cessation intervention for disadvantaged women. I'd like to acknowledge the kind invitation of Research and Development. I also work as part of the team in terms of knowledge translation. And I would like to acknowledge my collaborators in Trinity College and also in the Irish Cancer Society, in the HSE, HRB Trials Methodology Unit, and also Edinburgh Napier and University of Edinburgh. Okay, so traditional research dissemination involves academic scientific papers and conferences, but that can reinforce passive relationships among those who produce the research and those who use the research. It may fail to reach practitioners and policymakers who have the ability to use the findings and put them into practice. On the other hand, active research dissemination is a two-way dialogue between researchers and non-academics to disseminate evidence-based interventions using planned strategies. It can facilitate incorporation of evidence-based interventions into routine care, enable researchers to identify practice and policy priorities, new research, and thus reducing the evidence to practice gap. Engagement of different types of stakeholders, patients, research participants, practitioners, and policymakers is at the centre of active research dissemination. So the We Can Quit was a community-based intervention which was developed by the Irish Cancer Society, the Irish National Women's Council, and the Institute of Public Health in Ireland, specifically tailored to socioeconomically disadvantaged women smokers who have the highest rates of smoking in Ireland, and in the context of increasing lung cancer incidence in women. It was developed using the socio-ecological model, which takes into account individual, community, and population levels, and using a community-based participatory research approach. And CBPR is a form of research that involves engaging with community stakeholders with the aim to improve the development, implementation, and sustainability of evidence-based interventions. So the co-creation of knowledge through engagement with relative stakeholders to active decision-making about a health issue, it's expected to lead to more meaningful research outcomes for patients and care providers and communities. So the core components of the We Can Quit programme are group-based support once a week for 12 weeks, delivered by trained lay community facilitators who are women from the same socioeconomic background, many of whom are ex-smokers themselves, and that have been trained to the HSE National Standard for Smoking Cessation. There is also access to nicotine replacement therapy for those who wish to use it, and individual one-to-one text support between sessions. Central to the We Can Quit programme is using a partnership approach, community knowledge, expertise, and resources, and celebrating achievement at the end of the programme is a key part as well. So the intervention was tested in the We Can Quit 2 pilot trial, which was a randomized controlled trial. The overall aim was to determine the feasibility and acceptability of the intervention and of the trial processes. It was conducted in 4 consecutive phases or waves, each one taking place in an allocated matched pair of districts which were randomized together in Ireland. So local advisory groups were established in each district pair to support the trial implementation, which mainly included on-the-ground establishment of research sites and the planning and execution of a recruitment strategy. The comparison was the HSE's one-to-one smoking cessation services service with an average of 6 to 7 individual contacts delivered in person or by telephone by a smoking cessation officer. And just to point out that engagement of the local advisory groups was central to all phases of the trial, from design to implementation. Knowledge exchange is the interactive interchange of knowledge between research users and research producers used to disseminate scientific evidence. And a secondary objective of our trial was to develop strategies to optimize the recruitment and dissemination of findings to trial stakeholders to inform knowledge exchange and future research. And our knowledge exchange activities were academic publications, an accessible policy brief, and a knowledge exchange workshop. So these are 5 of the academic publications that we have produced. We also produced 2 trial protocols as well. The overall trial findings were produced earlier this year in nicotine tobacco research. Our accompanying embedded process evaluation was published in August of this year in BMC Public Health. We also have a paper on knowledge exchange and dissemination in the International Journal of Environmental Research and Public Health earlier this year, a systematic review and meta-analysis, and also a methodology paper in terms of evaluating the trial design. Our policy brief was a 2-page document, a plain English summary, which incorporated a description of the trial methods and the main findings and recommendations arising from the trial. It was distributed to the local stakeholders involved in the conduct of the trial and to key national and regional practitioners and policymakers with an interest in tobacco control. And I know you can't see this in any great detail, but this was our back-to-back, our 2-page policy brief. Just to draw your attention here to the nice pictures of the ladies who celebrated their achievement at the end of attending the We Can Quit programme. So the next activity was a single online workshop that we held in November 2020, originally scheduled for May of that year in terms of 2 face-to-face workshops, but we couldn't do those, of course, because of COVID. Our objective was to capture the stakeholders' views on the trial findings and their experiences of being involved in the research, so that we could share the findings of the trial and create an opportunity for our stakeholders to contribute to the findings and give us their reflections. The implications for policy and practice were very much part of the workshop. All of our invitees received the policy brief beforehand, and you can see here on the right we invited 176, so we had a very wide reach. We had the local advisory group members, our research partners, our HSE and Irish Cancer Society representatives, our community facilitators and HSE smoking cessation officers who deliver the programme, the local area partnerships and community development organisations, with community pharmacists, GPs, primary care centres, our regional and national policymakers and NGOs who are interested in tobacco control policies. So on the day we had 2 predefined areas. We wanted to look at key improvements to enhance community engagement, recruitment of participants and retention of participants, to inform the design of a potential future definitive trial. And the second stream was the key policy and practice priorities arising from the research. After the workshop, the day after, we sent out a separate anonymous online questionnaire in case anybody had further reflections that they hadn't maybe the opportunity or which they later reflected upon. And our analysis was done by field notes and questionnaire responses. So turning to our results, well, we had 41 attendees, which was sufficient. Obviously, we would have liked it to be higher, but that comprised HSE and ICS representatives, 7 of those, the delivery partners involved in setting up the local advisory groups and delivery of the recruitment in each trial districts, and the HSE representatives who were experts in smoking cessation and trained the trial programme delivery personnel. Our programme delivery personnel that I mentioned previously. The local advisory group members, we had 18. There were representatives from community development organisations, local area partnerships, primary care workers involved in the trial planning and promotion and delivery of the recruitment strategy, and local authority representatives from the cities and counties in which the trial took place who were involved in planning trial delivery. We had just 3 regional policy makers, a community health officer, a primary care development officer, and a health promotion officer from a trial area, and 4 national policy makers, 2 from the tobacco and cancer prevention national programs, 1 from a voluntary organisation working to reduce tobacco use, and 1 from a public education charity interested in addressing inequalities. So we then classified our workshop findings into 3 overall themes and a number of sub-themes. And our predetermined themes were community engagement and participant recruitment, retention, and the policy priorities arising from the research. Now, workshop attendees highlighted that the biggest challenge to community engagement was the limited time available to build strong, trusting relationships with the community partners and achieve broader engagement with the trial. But our trial recruitment in 4 waves allowed an iterative learning process with adaptive improvements implemented after each iteration. The plan for the final trial wave benefited from an extended 9-month engagement period with the community stakeholders, and that was a key factor in reaching the expected recruitment target in that wave. We weren't successful in terms of reaching the recruitment target in the earlier waves, but we were in the last wave, and we felt, and the feedback was very much about that extended period of recruitment. Attendees highlighted the variety of methods and the value of using a variety of methods to promote the trial. The LAG members used direct and indirect strategies to reach eligible women from the general population, and that included everything from word of mouth, pop-up stands in community venues, leaflets, the social media Facebook sites of the local community organisations. Also, the availability of myself and the research team to discuss the programme in communities and with the primary care stakeholders, that was recognised as important in connecting the fieldwork with the research partners. Workshop attendees, they also recognised the importance of engaging GPs and primary care workers at the earliest stage of the research process because of their limited time, and they highlighted the challenges of maintaining the participation of GPs and primary care workers during intervention delivery. So the use of community social prescribing pathways to signpost to health and wellbeing programs such as We Can Quit was a potential solution recommended to support recruitment. And social prescribing is a way of linking patients to non-medical sources of support within the community, based on the recognition that social determinants of health have a significant influence on health outcomes, and that was particularly important, a recommendation arising from the workshop. So in terms then of retention, 4 sub-themes came up there: the reasons for discontinuing the research, tools for encouraging attendance, planned support after intervention delivery, and participants' low literacy. So I'll just turn to retention there. The main reasons that the workshop attendees highlighted were basically women dropped out just because of feelings of not being ready or able to quit, fear of admitting the need for help to quit smoking, the recognition that women's families and social environment might be a source of stress or represent complex reality that can hinder participation through a lack of support or through the family members smoking themselves. And low literacy was a very important factor that was highlighted. So the solutions then I've divided into encouraging attendance, where things like avoiding summer holidays, winter nights. They recommended an introductory night with former We Can Quit recipients so that they could share their experience and promote better engagement. And a dedicated week during programme delivery with participants' family and friends, because part of our research we found that women were able to influence their social networks, so engaging them in the actual delivery process would actually was brought forward as a potential solution to try and achieve greater and ongoing engagement. So in terms of encouraging sustainability then, After the programme, keeping in contact with women by text or email, maybe 1 to 3 months after intervention delivery, and encouraging women to keep in contact by joining other community programmes. And it was felt that that would have helped data collection at the 6-month period after, because our retention rates were low. We had 50% after at the end of the programme, and that fell to 47% 6 months after, which was our latest data collection period. So in terms of the low literacy, they recommended simplification of the data collection forms and the PIL. Now, we were in the throes of GDPR, so it was really difficult to simplify and meet GDPR requirements. We did have all our materials literacy proofed by NALA. But they recommended short videos, actually, which I think is a very useful thing, replacing some of the material with that. And they also suggested more resources for the community facilitators to address low literacy. In terms of the policy priorities, the big things were around NRT and prioritising funding for interventions for smoking cessation interventions tailored to lower socioeconomic groups. Some of you can see there were administrative barriers to accessing NRT, because even though NRT was provided free during the trial, the cost for non-GMS was borne by the trial funding, but for the GMS ladies, they had to go to their GP to get a prescription. And there were issues here. I mean, one of the community facilitators said, one of the ladies said, I can't even get an appointment. It takes 3 weeks to get an appointment. And another of the community facilitators said, and then when the pharmacist confronted the ladies about the prescription, they felt they were being put under a bit of pressure to get the prescription off their doctor, and they were stressing over it. So that is something which is important to bring forward. I mentioned the need to prioritise funding for community-based interventions directed to lower socioeconomic groups. And I also recommend the literacy, obviously, as a policy issue as well. One of the women said, I can't spell for diamonds. So I found it difficult if I was to write in it. That was the journal that was used as part of the intervention. So turning now to our overall conclusions, our dissemination workshop and our dissemination strategy overall, I mean, we successfully engaged a mix of community and statutory stakeholders representing different voices and perspectives. It provided a final feedback loop with the key trial stakeholders as part of a longer community engagement process, because we had multiple interactions during the trial process with our wonderful PPI and our community organisations. Joint reflection among the non-academic stakeholders and researchers facilitated new insights and a deeper understanding of local women's needs and context to allow them to fully participate, not just in a trial, but in smoking cessation services that are geared towards them. We gleaned a set of practical strategies to enhance the design of future research implementation, and I've given you examples of those. And in terms of key recommendations, dedicated time to build relationships with local stakeholders who have a tacit knowledge of their local context, and connecting with the existing social prescribing networks were key recommendations. And just to say that despite the low response rate, we felt the online approach was a successful medium for stakeholder engagement. And then in terms of our immediate impacts, well, our dissemination encouraged the joint reflection on new research findings, increased the understanding of the barriers and facilitators to SED women's engagement in a smoking cessation intervention, and assisted in developing recommendations and outlining policy priorities which can be implemented in practice. In the longer term then, we expect our findings to be generalisable to the development of other community-based behavioural change interventions in lower SED groups. And We Can Quit has now been included as a programme under the National Healthy Ireland Strategic Action Plan 2021-25 to address health inequalities by trying to promote healthy behaviours in SED groups. And the findings may be used to optimise the design of definitive RCTs to test the effectiveness of these interventions and to enhance their sustainability, thus contributing to a reduction in health inequalities. So I'd just like to acknowledge very many people. I probably have left people out, but particularly obviously our funders, the Health Research Board, who funded it under a Definitive Interventions and Feasibility Award. So I will leave it there, and just to say thank you very much for your attention.
Thank you so much, Catherine. That's a really